And Ann, I think you're opening.
Oh, I thought it was you. Are we ready? Great. Good
We're gonna
afternoon.
wait 1 second. I think we're just, we'll start in 1 minute as people kind of file into the room. Okay, we're good to go.
Great. Good afternoon and welcome. I want to thank everyone who's joined us today for the National Housing Conference Health and Housing webinar. I'm Ann McCulloch and I'm chair of the NHC's Board of Governors. I'm also president and CEO of the Housing Partnership Equity Trust, a social purpose REIT and a longstanding NHC member. While the overlap of safe and affordable housing with health and healthcare is always an important issue, it's certainly taken on new urgency in 2020 as health and housing professionals alike are really confronted with the relationship between having stable housing and having positive health outcomes. In the midst of this awful pandemic, affordable housing owners and operators find themselves on the front lines, ensuring their residents are safe and healthy, while also making sure that their property management staff stays safe and healthy. For this afternoon's event, we've put together a really exciting panel of experts that will discuss the state of health and housing today and look at new developments and the issues highlighted in NHC's Health and Housing Report, which was published last summer. Both the report and today's webinar were made possible by a generous grant from the Kresge Foundation. We're pleased to have with us David Fukazawa, Special Advisor to the President at the Kresge Foundation, who will moderate our panel today. So thank you, David, for joining us. We're especially excited to hear from our keynote speaker this afternoon, Dr. Regina Benjamin. Dr. Benjamin served as the 18th U.S. Surgeon General from 2009 to 2013 in the Obama administration, and is currently a health and safety advisor for Zillow. NHC President and CEO David Dworkin will moderate a Q&A discussion with Dr. Benjamin. Afterward, we'll hear from our health and housing panelists, two of whom participated in NHC's report, Promising Health and Housing Collaborations. The panel includes Rachel Solotaroff, President and CEO of Central City Concern, Nehru Goben, Director of the Office of Housing and Homeless Services for the Tennessee Department of Health and Substance Abuse Services, and Mr. Fukazawa from the Kresge Foundation. Following the panel discussion, they will take your questions. If you'd like to pose a question during today's webinar, please do so in the Q&A box and not the chat box. Thank you to the entire NHC staff for organizing this important and timely event. And thank you to all of our participants for joining us. With that, I'll turn it over to David to introduce our keynote speaker.
Thank you, Ann. We are indeed navigating uncharted waters in health and housing. I'm looking forward to hearing from today's experts so we can all leave a little more informed about how housing professionals and health professionals can support one another to ensure better access to safe housing and the improved health outcomes it affords. As Ann mentioned, our 2019 Health and Housing Report, funded by a grant from the Kresge Foundation, examined the growing body of research that links affordable housing to better management of chronic diseases, a reduction in the net cost of medical care, and most importantly, improved overall health and well-being. When we authored the report, which showcases 3 exemplary cases of health and housing collaboration, we never imagined the challenges we'd be facing today. And yet, the spirit of collaborative work and potential solutions discussed in the report remain as relevant as ever. I am thrilled to introduce a distinguished leader in this field, Dr. Regina Benjamin, who will discuss some of the challenges and solutions that lie ahead in health and housing. Dr. Benjamin served as the 18th U.S. Surgeon General and is currently working with online real estate platform Zillow, where she serves as their health and safety advisor while continuing her family practice in Alabama. Prior to her government appointment, she had spent most of her medical career serving poor families in a shrimping village on the Gulf Coast of Alabama. In 1990, she founded the Bayou La Batre Rural Health Clinic, and the following year, she obtained an MBA from Tulane University, which I expect is essential to successfully managing a rural healthcare facility. All of her accomplishments are too great to mention here, but I was particularly impressed that Dr. Benjamin worked with the University of South Alabama's College of Medicine's telemedicine distance learning program, which offered medical education and healthcare to clinicians and patients in rural areas through a telecommunications network in 2000. That was 20 years ago. Talk about being a pioneer. Most of us are just learning how to use Zoom. Dr. Benjamin was the only doctor in Bayou La Batre, and she persevered in running the community's health clinic despite having to rebuild it 3 times. In 1998, after it was flooded by Hurricane George, in 2005, after it was destroyed by Hurricane Katrina, and again in 2006, after it was extensively damaged by fire. I think we'll have to have her back for a climate impact seminar as well. In fact, she mortgaged her house to help finance the clinic's reconstruction after Katrina. And while the clinic was being rebuilt, she made house calls to see her patients. During her term as President Obama's Surgeon General, Dr. Benjamin focused on promoting preventive health measures and implementation of the Affordable Care Act. She currently serves on the faculty of Xavier University. At Zillow, Dr. Benjamin is lending her vast healthcare expertise to promote health and safety protocols and policies in the real estate sector. She's also advising on Zillow's Moving Forward Stay Safe initiative, launched this summer in response to COVID-19, which combines best practices, safety standards, and expert public health guidance with Zillow's technology to keep real estate professionals, prospective home buyers, and homeowners safe. I am looking forward to getting Dr. Benjamin's take on the current public health landscape, as well as learning about the insight she's gained during her recent work with Zillow into how the global pandemic is affecting housing. And with that, let's get to know this amazing leader and physician. Dr. Benjamin, welcome.
Hello, I'm trying to figure this out. There we go.
Go.
Hello, everyone. Hi.
So thank you so much for joining us. And let me just start with an important framing question for our audience, which is, can you tell us about the role of the Surgeon General and how does it relate to other major health policy leaders like the Centers for Disease Control and the National Institutes of Health? And you might also add how you get to wear that really cool uniform.
Good. Most people know the Surgeon General by the warning on the cigarette package. We really are about prevention, all about prevention. There are 2 major roles for the Surgeon General. One is America's doctor, giving the American people and the world the best public health information that's available so you can make good public health decisions. And so that's one of the major roles. The other role is as the leader of the United States Public Health Service. The Commissioned Corps officers are, I had 6,500 officers under my command. We're a branch of the military. We're one of the two branches that don't carry a gun. We always say we'll shoot you with a needle to vaccinate you, but we don't carry a gun. It's just like the Air Force protects the skies, the Navy protects our shores, we protect the public's health. And so that's the role of the Public Health Service. And my rank was a Vice Admiral, 3-star Admiral, although the title is Surgeon General, it's like Secretary General. I was actually a 3-star Admiral, and people always ask, the only person that outranked me in the US Public Health Service was the President Obama.
Well, thank you. So on everyone's mind every day is COVID-19 and the pandemic. Since it's front and center to so many of our concerns and our work, we just hear so much from the media, and it's a challenge to sort it all out. Now even the CDC's independence is being called into question. What do you think we should be expecting this fall as the flu season evolves through the winter months? And how do you think we should be really managing our own self-care during this time?
Well, as I mentioned, I'm all about prevention. And so it's really up to us to try to do what we can to protect each other and protect ourselves and protect our families. And that's a major part. I want to back up a little bit and just talk about the beginning and get to where we are now. You know, early on, when we learned about COVID-19, we understood that health disparities existed, but we also understood that COVID-19 affected people with pre-existing illnesses or conditions, underlying conditions. And we thought about things like cancer and strokes. What we didn't really think about was people with high blood pressure, heart, a little irregular heartbeat. We didn't think about somebody who just basically had diabetes. Those, what we wouldn't consider strong underlying illnesses, but they did. But what we saw was that these were the people who were starting to be affected more. It came in sicker, we came in much more affected. And so the American Heart Association looked at the cardiac arrhythmias and found that underlying irregular heartbeat was really important. And we found that particularly people in minority communities were being affected the most. We came in sicker, they came in much faster, and were dying much more often. And we found that that wasn't really because of genetics, it was more because of the social determinants of health. And as you know, your zip code is a better predictor of your longevity and health than your genetic code. We then started seeing the same sort of things happening in rural communities. And that's where we are now. And so as you look at all of these things, we have the frontline people that are getting sicker. And where we are is that we really need to start protecting each other, protecting those frontline folks. And it's a major social determinant of health is housing. That's one of the things that we look at as a basic need, shelter. Ever since man has existed, we need to have food and shelter. And so housing was a major part of that. And that's where I came in with Zillow, because Zillow was starting to look at this. We had the National Prevention Strategy that I released as a Surgeon General. And as I always say, health doesn't occur in the doctor's office and the hospitals alone. It also occurs where we live, where we learn, where we work, where we play, where we pray. It's in everything we do. And housing was part of that. And this was a way for us to start at least addressing this particular part of social determinants of health. Where we are now is the same place that we were back in March. We still have to do the very same things. We're all getting fatigued, we're getting tired, but we have to continue to be very vigilant. And you're going to hear me say this over and over. Do the 3 W's. Wear your mask, wash your hands, and watch where you step. You're distancing. Stay 6 feet apart.
That's really helpful. And tell me, when we talk about underserved communities, there's so many other social determinants that are going on, and it's hard to get that message out. There's also a certain skepticism about the medical community, science, and government. How do we get through to get that message out there and really help bring some of those numbers down where minority groups are really being impacted in a horrifying way?
You know, for us in public health, it's becoming very frustrating to see how much misinformation, wrong information that's out there. So we're still trying to beat that drum beat and say, these are the things you need to do. Try to find the most credible sites and the credible places that you can find information. Unfortunately, some of it has become politicized, so we have to go an extra step and do some extra homework at times, but there are still credible sites out there. There's the American Public Health Association, there's the American Heart Association, the Robert Wood Johnson Foundation. Those organizations can verify what you're seeing in other places or discredit them. Right now, they're pretty credible. There are many others out there as well, but verify what you see, because there is so much out there, and there's so many. Some of this stuff is being done purposefully to cause us to be distrustful, not to trust anything, not to trust scientists, not to trust our government, not to trust each other. And so just understand that that's there, and do your little bit of extra homework and try to get the best reliable information that you can.
Yeah, it's really scary when you see this contempt for science. You hear about it on many levels, not just, we hear about it from the White House, but we also hear about it from people we know and from sources in the media. It was shocking to me. I'm sure it has been to you.
And one of the things I'm, as you mentioned in your opening comments about me, I'm in the South, and I'm here in Alabama on the Gulf Coast, and we have hurricanes a lot. And I try to talk to people about, give the example of a hurricane. When the weather service tells us there's a hurricane out in the Atlantic or out coming into the Gulf and coming our way, we make preparations. We don't question them whether they're correct or not. We don't say the sun is shining, so they don't know what they're talking about. We understand it. The same thing with science and infections and infectious disease like COVID. When we give you information, it's based on everything that we have available, and we want you to take it seriously and act appropriately because of it.
Yes, for sure. There's so many of our members are housing practitioners. They're involved in either caring for homeless populations or building and developing or managing affordable apartment buildings. There's been a lot of back and forth in terms of how the virus spreads and how property managers should ensure the cleanliness of their buildings and ultimately keep tenants healthy. What advice would you give to building owners and property managers today in terms of best practices for keeping surfaces clean and ensuring healthy air quality and other safety measures?
At Zillow, we have the Move Forward, Stay Safe program, and there's quite a bit of information on the Zillow website regarding it. But basically, we recommend that when you don't have to meet in person, that you do it virtually as much as you can. Continuously wipe down, wear protective personal equipment, gloves, of course your mask, that's always first and foremost. Wipe it down, high touch areas very frequently, and stay your distance. And when you have people who may have been exposed, or someone that has been sick with COVID or COVID-like symptoms, don't engage with them, and try not to show your property or anything. And we are recommending 14 days of someone who's been symptomatic, or someone who's been sick with COVID, that you stay at least 14 days before you personally engage with them. And follow the website, look at information to see what's changing and updating. There's a lot of technology that's available that you can do virtual tours that you can do, sign documents online. Those sort of things are very helpful in today's environment.
That's great. And let me ask you just to go a little deeper. Let's talk about the homeless population, which really is a special needs area, and understandably can really impact our ability to both protect people and also curtail the spread.
Very much so. And, even though I'm in a rural area, we have a number of homeless in our area as well. And one of the things I just a couple of days ago was seeing a couple of my homeless friends and patients that are there without mask. Give them a mask. I mean, they would put a scarf or something over because they're trying to do their best. Many of the homeless people have been struggling and trying to survive. Anything we can do to help them to make it easier would be helpful. Many of the communities are trying to open shelters and places. They have very difficulty finding places to take a shower, bathrooms, and many of those are starting to close. So it's really a challenge. And we hope that local governments, local communities and things would step up to the plate, but oftentimes we have to be a part of that as well and do our part as much as we can to try to make sure that you understand that people don't have the same opportunities as others. The other part is they're finding homelessness is one of the things where people don't necessarily have not only not a place to sleep, but no place to keep their belongings. Just all of those things come into play, and whatever policies and things that we start to advocate for, we need to make sure that we remember that there are people who don't have a shelter over their head.
Well, we were successful in getting some money for homeless prevention and treatment in the CARES Act. We've obviously had enormous frustration with additional money for that and rental assistance to help people from being evicted and potentially becoming homeless. I know the Speaker and Secretary Mnuchin are working on this at this very moment. Hopefully we'll get some relief, because I really don't think it can wait until after the election, certainly not till next year.
And those of you who sit on boards and things, I'm on the board of the Kaiser Permanente board, and we allocated $40 million to homelessness. But if you're in a boardroom or in a place that you can use your voice, please do, because every little bit helps.
So we got a question. I'll take people in the South definitely question the validity of hurricane forecasts. We often see people who say, I'm staying in my home and I'm going to ride this out. You see it up in Northeast too. There has been a continuous change in information on both projected hurricane paths and advice on the pandemic. Let me just ask you personally, with your in your community, with your friends and people that you treat, what's been effective for you in really kind of helping people understand both the seriousness and how it potentially impacts them when they may not be experiencing it until it's too late?
I'll just respond to that a little bit about the hurricane part. Many people with the hurricanes, they don't doubt that the hurricane's coming. They just say, I'm going to run it out. I'm going to ride it out. I've rode it out so many times. I'm going to do that. With COVID, many people doubt that it even exists or that it's real. And that's the big difference that I see there. Much of the things that we're seeing is, I don't have an explanation as to why, but there is a lot of information that's causing a lot of this distrust. Normally we'd say, yeah, that's probably bad, but then it just goes on, and these conspiracy theories, there's all this, even there's a string of truth to something, but you take it down this regular negative path, so that on both sides you're questioning each other, and you get to a point that you don't believe anything. You don't believe the church. You don't believe in the fire department. You don't believe in the police. You don't believe in anything. And so that also has a toll on democracy, because if we can't believe in each other, how can we have a democratic society?
Yeah, that's certainly something that, we're all seeing in real time. Um, let me ask you a little bit about the vaccine, and can you help us understand what's the process that's happening right now? It seems like they've made a lot of progress in identifying candidates, and they go through these different levels of testing. Um, what should we expect in terms of timing, and what should we really look for to be reassured that a vaccine is going to be both safe and effective?
As far as timing, as a scientist, I have to say, I don't know. I just don't know, and none of us know. What we have to ensure is that the testing is valid, that it's gone through rigorous testing, and that we're not, or the companies are not cutting any corners. We need to make sure that we're using the standards of care when we start to do our validity testing. The pharmaceutical companies, the new ones, the fly-by-nights, maybe don't have as much to lose as the more established ones, and pharma and the group came out as a group to say, we're going to use our standards of care, we're going to use valid testing when we won't release anything too early. We have to verify those things. And it's one thing, and this gets confusing, is that we can use vaccines at a certain point because they've shown to be some effectiveness. If someone's at their death's door, at the dying bed, we can use it in an emergency situation. That's a different situation than trying to use it on a healthy population when we don't know the long-term effects of a healthy population. And so that's why when we say we don't want to give a vaccine out too soon, you can get to different phases of trial testing and you can show positive results, but you may get to the next phase and show that it was harmful. And we don't want to harm. And as a physician, my first promise has always been to do no harm. And if there is some harm to be done, you need to know it up front.
So help me with this, because we, as policymakers and the coronavirus task force, have this balancing act, because on the one hand, people are dying 1,000 a day, and on the other hand, you have both the risk and benefit of a vaccine. So if you were Surgeon General today, what would you be looking for to say, how do you find that right balance?
I don't think it's a balance. It's a treatment is a treatment. We need to be researching for treatment as well. With the vaccine, you've got to give it time to show that it's effective, for one, and we also have to give it time to show that it's not harmful. And that takes time. That's not something you can rush. You've got to do the test. You've got to make sure that you test a number of people in the right populations, that you didn't test it all on males or just all on females. You've got to bring in those populations that it could affect differently. So at the end of the day, it takes time. And we're being very we're frustrated, but we knew back in January that it was going to take time to get vaccines on the market. Once you discover that vaccine, then you've got to put it into production, and you got to ramp up production, and that also takes some time.
Let's first of all, I just want to invite people to type questions in the Q&A section, and we'll take them as they come in. But I want to talk to you a little bit about PPE and what happened there. I mean, it's I have family members who are doctors. They are still wearing N95 masks all day long, sometimes longer. The protocol on that, I believe, is that you throw them out with each patient. Certainly people are not doing that. And not to mention all the other PPE. What do you think happened there? And how do we get on top of that so that healthcare workers and first line responders actually have what they need? Not to mention the rest of us.
Looking back into the first part of the year, we didn't know how this virus was spread. So we were trying to cover everything we could. The droplets and things, that's why you wipe things down and do. We did not know that it was spread by breathing, by air. I mean, droplets and coughing and things is one thing, but when you just breathe in the same air is a different set of conditions, and we didn't know that, and so we didn't have as many available PPE. We didn't have as many available masks. So the first thing was to try to protect the healthcare workers, the people that were in the ICUs treating folks directly. And so that was where you saw, trying to say, let's prioritize the folks every day. And some people were saying, everyday person doesn't have to have a mask because they didn't know about the breathing. Once we learned that you could catch it by just breathing in aerosol through air breathing, it changed. We still didn't have the production and the numbers and the amount to cover everyone. And that became a major priority, a lot of controversy about how you could get it, how you couldn't. We're still at a point now, most people can get a mask, but they're different kinds of masks. And so a lot of that led to confusion as well. And remember, we were in the idea that we were going to be doing this for like a month or 2 or 6 weeks. We had no idea it would be this long.
So let me understand a little bit about the mask, because it can be very confusing and it's such an important part of how we protect ourselves. There's the N95 mask we've heard about. And my understanding is that actually protects you from the virus when you're wearing one. But other levels of masks are different. There's, they say the 3-layer mask. There's the mask that we buy at the CVS. And then there are homemade masks. Some of them are sewn by my wife sews masks. She does them with felt and fabric. And then there are bandanas and various neck coverings. Help us understand what that all means and how those work. And am I protecting you or am I protecting me?
Both. I'm not an expert on the mask, but I'll start with the N95 mask. Those are and there are different types of N95 masks as well. They're the big ones, but they fit tight around your face, and they have a seal, and so they're very tight and you can get a rash from wearing them too long. And so it irritates your face, and you wouldn't want that for everyday public to be wearing, because it is can have some, as we call, side effects. But it is important when you're in an ICU bed, you're treating someone who is infected, that's important. It's really important. For the everyday person, what we find is that the 2-layer or 3-layer cloth over your face to cover your nose, the bridge of your nose, and your chin, and make sure it has a seal, or it covers, so that what you're breathing in is not as much, but more importantly, what you're breathing out. You're protecting yourself some, but you're protecting the next person more than you're protecting yourself, because whatever's coming out is not getting out. And so when you do that, if everybody does it, the amount of virus circulating in the air around each other is less. So you're going to be protecting both. The idea of just keeping the amount circulating in the environment down, you can see results from that.
So that's really helpful, because I think there's a lot of confusion about, I think, I'm sure that there are some people out there who are saying, well, I'm not afraid, so I don't need to wear a mask. But they don't necessarily understand that, in fact, wearing a mask is about caring for the people around you, even more than it's about your own, risk tolerance.
And some, we've tried to make that argument and help people understand that But then you've got this group that says, well, I have a right not to do this and these rights. But what they tend to forget is that in a democratic society in the United States, particularly in most democratic societies, those rights come with responsibilities. And when you have a right, but you also have a responsibility. And I guess an example would be when I get a driver's license, I have the right to drive my car, but I also have the responsibility of not to drive at 60 miles an hour in the wrong direction on the interstate. That is my responsibility. So with rights come responsibility, and we forget to say I have that right, but also have a responsibility to others.
That's a great point and a great metaphor. Let me ask you about efforts to reopen. There's obviously enormous COVID fatigue. My wife and I are very strict about this, and we feel it regularly, especially over the last few months. So what are your thoughts about, say, returning to work in areas where most people are teleworking? What are the benchmark or thresholds you would recommend for getting back to semi-normal? And how should we be thinking about that as we, who manage organizations, start to think about bringing people back? Or should we really just stick to the working from home model, particularly as we go into the fall?
If you're able to work from home, that would be the first option, the first choice. Unfortunately, everybody's not able to do that. And as you mentioned, we're getting COVID fatigue. We're all getting tired of this. But the amount of virus circulating in the community is just as much as it was back in March. And so we're still at risk. We've learned some things. We've learned how to do some things better. We've learned, what we can do to socially distance ourselves, that we can wear the mask, and there are ways to start to reopen society a little bit more in a safer way, but we have to do it in steps and in safe ways. I'll go to the example of medicine. Much of the hospitals and clinics and things were closed down, and early on. Now we've learned that we can do certain things. We can wear the mask, we can disinfect, we can do things by telemedicine that we didn't do before. We've been, as you mentioned, we've been trying to get people to do telemedicine for years. Now this has really brought us to a peak where we really know we have to do it. So as we open, we have to get, people can't stay at home forever. They can't afford it. The economy is really tough, but we can't afford not to do the things we need to do to get the virus under control. Our economy, and as we say, back to normal, it'll be a new normal, but we can't even get there if we can't get control of the virus in the community.
So let's get back to the housing issue and talk about apartments and real estate. You've been doing a lot of work with Zillow on this, and tell me a little bit more about that, and what should we as practitioners be thinking of in this space?
My first and foremost is always take it as an individual. I mean, and take care of things at home and what you can do and what you can influence. And many of us can do that. As a industry, there are certain things. I mentioned doing the virtual tours. And some people will want to have a in-person, make the appointments. And to do an in-person visit, you can do that, but also ask those questions. Ask the questions: have they had symptoms? Have they been exposed? To try to protect the customer and your employees as well. And once you've done that, you've pretty much done most of the preventive things that you can do. And once you're there, wear your PPE, and once you're there, stay your distance from each other. But we have to start to move to start to reopen. It gets into the challenges of when we talk social determinants. do you get back to work, or do you not be able to put food on the table? So it's quite kind of that simple, that we have to start doing things. But if you can afford to work from home, if you can afford to have your employees teleconference in for most things, that would be the first choice.
So as you know, we've looked at housing impacts and health outcomes. So we're going to have a panel discussion on that shortly. Can you share some of your thoughts on the challenges of integrating some of the indirect health impacts into health policy and other areas of public policy, such as housing, that really are important to keeping people healthy, but using the opportunity that we have in our world to contribute to that?
When it comes to policy, there are just so many things that's impacted. And I'll go back to the telemedicine part. I just did a task force on telemedicine policy, and the things that we saw, some of the rules were relaxed so that telemedicine could be incorporated better. People like being able to do the televisits. They're not going to go back to completely. They're like, I like it. My Medicare patient says I don't have to get up and get dressed and go to the doctor. I want to do it. There are times when you can't do that, though. And so one of the things we had to make sure in policy is that we relax what we call the HIPAA laws, the laws around personal information being shared and security. We have to go back to make sure that your personal information is secured, that you're not at risk of losing your personal information to some hacker or something. So we have to put those assurances back, and we have the technology to do that. But that needs to be part of policy. The same thing, we had to look around licensure and making sure that the person that you're engaging with as a clinician is legitimate, that you're not getting someone that's not legitimate. So all of those things have to be put in place in policy. On the other hand, telemedicine also increases and improves access to care, because you have easier access to your clinician. For example, a mom or a single mom who's working 2 jobs doesn't have time to take off the afternoon to go to the doctor, but she can schedule a telehealth visit during her lunch break and go find a quiet place and have that telehealth visit, and it's taken care of. So it's improved her health access, because she can only have to go once versus going 3 or 4 times to the doctor, that sort of thing. Those are the kind of things that we'll see, and we need to make sure that policymakers understand that sometimes they think increased utilization means increased cost. But if you're keeping people healthy and keeping them from getting sicker, the long run, it's going to decrease cost.
So let me ask you a question from the audience. What new benchmarks and standards should affordable housing developers and operators look at to have better health outcomes in their properties and for their residents? Many of our members actually are building and developing affordable housing now. How should we be thinking about this as we plan to the future?
Yeah, again, I'm not an expert in housing or building, but I just, common sense would say making sure that the homes are stable, that they're constructed well, they can withstand certain things that we're seeing now, like hurricanes here, that they can withstand earthquakes, those things that people won't get harmed if you had some disaster to occur. So it's putting as much of that into place. And I think that will require policies to say, you don't get approved until you do these things. I mentioned hurricanes again. I just went through Hurricane Sally, and so we didn't have electricity I didn't have it for 10 days. Some people here still don't have electricity. Some of the things like we had to have gas generators, but when you don't have electricity, the gas stations can't pump gas because they require electricity for the pumps. The generators require gas. So now I'm learning more about solar panel and solar power generators, and maybe we can put some of those sort of things in the new affordable housing, so that people don't have to depend on fuel and to stay warm or to stay cool, and run their generators. So we can start to look at some of those things that decrease the maintenance or everyday outlay of your housing expense every month, not just when you buy the house, but what it costs you to keep that house up or keep that apartment up.
We got a question. I'm not sure if you can answer this or not, but can you recommend any good programs or grant programs to assist people who've been impacted by COVID, or organizations that have been impacted by COVID?
A number of the foundations are starting to put out some grants and some monies available. I'm working with an organization called Direct Relief, and we're getting donations coming in to help with, particularly around health disparities and issues around health disparities. We've concentrated our efforts right now into the community health centers, because they're located in underserved communities, and oftentimes their government funding doesn't cover these social determinants. And so the community health centers are places that you can go. Almost every foundation that I've talked to is trying to find some sort of social relief funds, some emergency funds. The March of Dimes, when it comes to children, for the American Heart Association, all have those. And those take time. And most of the time, everyday person doesn't know how to fill out those forms and things. So the community foundations in your different communities are often there to help you, put you in touch in the right resources, that they know where, funding is for food, funding is for, transportation. Those local community foundations can often direct you where to go, because it's massive right now.
So I know, you have some familiarity with coronaviruses, and you worked on SARS. When we're thinking about new construction, there's a wide range of what we call HVAC that is a lot of different cost levels.
Right.
How should we be thinking about air circulation, and is this something that's really going to be impactful, or is it something that are there other areas we should think about, really reserving funds within our pro forma when we're planning housing development?
I think it would be helpful if you can try to reserve some funds for it. I'm on the board of a company that supplies some of this kind of equipment to hospitals, but mainly it was around operating rooms, keeping the operating room sterile. That same technology is probably going to be built more to scale for the consumer. And so if you can find HVACs or something like that would keep your buildings and equipment and your air filtered, the increased safety would be helpful. And it also would give some peace of mind to people who go in those buildings and who work in those buildings, who live in those places. I think the technology is being developed more and more, but you're seeing some that are reasonably priced. So long-term planning, your strategic plans would be good to start to put those in place. They'd be good to put in place anyway if we hadn't had COVID, but even more so now to understand that.
We got a very interesting question here. I'm just going to read it off the Q&A. In regards to housing and its development in cities like New York, where the apartments are getting smaller, and there is a lack of affordability already. We see this in many parts of the country. We see a lot of multi-generational households. With the coronavirus, space is very important, both physically and emotionally. How can health and housing work together to advocate against developers that try to squeeze as many units as possible into a space, or for those of us who are developing units, really have to maximize every square foot And how do we balance that?
That's a challenge because there's only so much land, and the land isn't growing except maybe in Hawaii where there are volcanoes making new earth. The space is limited, and so we have to make the best use as we can. I'm a big proponent of as much as you can to try to get outside, to get into the environment. Green space is so important. So when city leaders and folks are starting to develop a development, or if they're developing a community, that you make sure that they allow for green space so that you have some space to go out. I'm also a big fan of the National Park Service. As much as those of you who haven't been to the national parks, they're wonderful, but they wouldn't have been here if we didn't have someone before us to save those parks for our use. So we need to do those things as well. If you have an opportunity in your homes to get a bigger space, you can, but many people don't have those opportunities. Using the public spaces for those who can get out would be helpful. Not just because it's fresh air you're breathing, which is important, but it's also good for your mental health. And we hadn't talked much about mental health, but a lot of this stuff can be very depressing.
Yeah, and I'll just put in a plug now for our COVID-19 Housing Resource Center, which is on our website. It's over 1,000 resources on COVID-19 and housing, but it also includes a section called the oxygen mask rule, which is anybody who's traveled on an airplane knows. So you have to help the person next to you after you put the mask on yourself so that you're available to actually help them. There's a lot of information there on self-care, which I think is really important for all of us, especially who are working so many hours and dealing with this in our communities. Let me
and
ask.
just to add a little levity to this, to talk about the mask, and you asked me about masks, that reminds me that we never think of that as a mask. We didn't think of the kind of mask we are down here in my part of the country. We think of a mask in Mardi Gras time.
Right.
It's like so many different types of masks that our world has changed.
It certainly has, and we have a big annual gala every year. We canceled our gala this year. We're still trying to figure out whether we're going to have our gala next year in June or in November or at all. I think the chances of it being a costume ball are very high with everybody wearing an appropriate mask. Hopefully it won't come to that, and we'll be in a different place. Let me ask you just any final thoughts you have or guidance for housing and health professionals as we work together to better serve American households.
For individuals, again, I want to just emphasize that it's important that you do those 3 W's. You wear your mask, wash your hands, and watch where you step. But also exercise and get exercise in, because we didn't talk about that a lot. And if you smoke, don't smoke. Make sure or try to encourage other people. I can't be a Surgeon General and not tell you about not smoking. So those things. But it's important that as in housing, that you understand how important and how basic it is for people to have safe, secure, healthy homes, that they can have a roof over their head, that in itself will add not only to the health of that individual, but to the health of their family and to the health and wellness of that entire community. And so the work that we're doing in this industry really does affect the overall health of our entire nation just because of that.
So I'm going to not let you off the hook without asking one controversial question. You were involved in the rollout of the ACA, Obamacare. The law is up for review by the Supreme Court. We don't know what they're going to do, but there's no question that the future of the ACA is at risk. What does that mean in the middle of a pandemic? And how should we be thinking about that? And if it is ruled unconstitutional, what do we need to do?
Well, the part that's really strong about it right now is the part about pre-existing illness. if I was talking to a patient yesterday who doesn't have a job anymore and she's trying to get on the exchange and it's taking her time, she can get on the exchange. But if the pre-existing illness portion is gone, she would have to wait, 90 days or whatever, or even if at all, to be covered. So that's a real challenge. I, of course, hope that it's not changed and we keep the Affordable Care Act in place. But if it is, we really will have a real challenge because we don't have anything to replace it with. If we had something to replace it with, I'd be more optimistic. We right now have people who are suffering for a lot of reasons, and this would be just one more thing on their plate. My preference and my thoughts would be we should be going in the other direction. We should be getting more people, more coverage during this time of a pandemic. We should be increasing our access to care, not decreasing our access to care.
Yeah, it has really made this whole issue so front and center and personal for all of us. Thank you so much. I really appreciate you making this time for us and your service to our country and all of our health and just your amazing experience in your life, which has just been so nice to get to know you.
Thank you very much. I was going to ask you if I could end with a poem. I was looking for it. I just found it.
That would be lovely.
Making all this noise here. I found it. And the reason I want to end with the poem is because I've been talking about individuals and I want the folks that are listening to know how important the work they're doing is and that you continue to do it. But it's a poem entitled God Minute, and it's by an unknown author, but it goes like this. I have only just a minute, only 60 seconds in it, forced upon me, can't refuse it, didn't seek it, didn't choose it, but it's up to me to use it. I must suffer if I lose it, give account if I abuse it. Just a tiny little minute, yet eternity is in it. I just hope that you'll take your God minute and continue to make a difference in the things you're doing every day.
Thank you so much. It was great, really wonderful getting to know you.
Thank you.
So with that, we are now going to pivot to our panel discussion. I just want to say that over the years, NHC has recognized the importance of the nexus between health and housing. Thanks to a generous grant from the Kresge Foundation starting in 2017, NHC convened a working group of health practitioners and affordable housing organizations to develop actionable strategies for how these two sectors can partner together to build new affordable housing, spur investment in affordable housing, and reduce medical costs. It's my pleasure to welcome our health and housing panelist speakers, Nehru Gobin of the Tennessee Department of Health and Substance Abuse Services, and Rachel Slaughterhoff of the Central City Concern, who both participated in the initiatives that we featured in our Promising Health and Housing Collaborations report, which examines how these strategies can be implemented. And last but not least, David Fukuzawa of the Kresge Foundation, who I am very pleased to introduce and who will moderate this important discussion. David serves as senior advisor to the president at the Kresge Foundation, first joining Kresge in 2000 as a health program managing director. He has more than 20 years of experience in philanthropy and a special focus on children and youth, which started when he was a youth worker and community organizer in my hometown, Detroit, and in Chicago. His work in Detroit would help him re-envision and redesign Kresge's approach to health grant making. Before his career in philanthropy, David served as director of human needs at New Detroit, Inc., where he was responsible for policy analysis and development, particularly in areas of welfare reform and healthcare reform. David is a Yale University graduate. At University of Michigan, we call that the Michigan of the East, and holds a Master of Divinity from Catholic Theological Union in Chicago and a Master of Science in Administration from Central Michigan University. David, we are incredibly thankful for your leadership in this space and Kresge's continued support of our work. I also want to note that Kresge recently announced its role in a major new affordable housing fund in Detroit, which I'm certain will be a model for the nation. So congratulations to you, to your colleague Wendy Jackson, and of course Rip Rapson on this initiative as well. With that, I will let you take it away and introduce our other speakers.
Yeah, so thank you, David, for that introduction, and thank you for having me join today's webinar. It's always a pleasure to hear Dr. Benjamin, and I'm glad to see her looking well and hale, even in COVID times. And I'm excited to moderate this panel for NHC to discuss your report, which came out last year. It might be useful for me maybe to say a little bit about why Kresge even sponsored this effort a few years ago. And I will say two words, two ideas, lead poisoning and asthma. We actually started out 12 years ago when I had a chance to sort of redesign our approach and create a new program under a new CEO at Kresge to think about how would a national foundation approach health, especially one that was not a specific health foundation. We're actually a community development foundation. And, we settled on this idea around social determinants, which by now everybody knows about, but which then was sort of a new idea for many, many people. And we, like a lot of foundations, were looking at some obvious social determinants, such as healthy eating, active living, so access to good nutrition and safe physical places to recreate and to walk and things like that. But we actually started looking at lead poisoning, and we're asking the question, why isn't more being done about this? Because we were actually within shooting distance of getting this problem solved. We could do this tomorrow if the nation had the will to do it. And that led us to a bunch of other things, all related to pediatric health. To make a long story short, though, over the course of a couple of years, we realized that these issues were not just simply related to substandard housing. It was related to the issues around affordability, which is related around issues of income inequality and race, insofar as the neighborhoods where people live, work, and play, many, many generations ago were determined, in many cases, by federal law to determine who lives where, and this was often along racialized lines. And so we know that many of the health disparities that we see today are certainly related to social determinants, but they're also related to where you live and the investments in those houses over time. And so we came to a point where we began to talk about housing as a fundamental social determinant. And at the time, we realized that hardly anybody was talking about this. It's hard to believe now, but we're talking about 9-10 years ago. We couldn't find a lot of people talking about it. Housers weren't necessarily talking about it. Hospitals weren't necessarily talking about it. But in the course of a couple of years, there began to be this focus. And actually, Rachel's going to be speaking in a minute. Portland was one of those places that began to recognize very early that people who are homeless and housing or health costs were actually deeply interrelated. If you're going to get control of health costs, we had to get people safely housed. And Portland was one of those places around the country that actually began to realize that pretty early. So our grant to NHC was really to try to capture some of the early innovation that we saw happening across the country. So that's kind of how we got into it. But before I go any further, I have to do a little housekeeping here. And that is, again, if you have a question, I think people by now know where the Q&A tab is at the bottom. We'll, of course, monitor those questions and try to answer them in order. This webinar is being recorded, and you will receive a link to the recording in case you want to hear any of this over again. And now I'm pleased to introduce today's panel speakers, who participated in the partnerships in NHC's Promising Health and Housing Collaborations report. And they will provide an update on their initiatives, speak on lessons learned, and how they're addressing the challenges during the current pandemic. So let me first start with Rachel. Rachel Solitaroff currently serves as President and CEO of Central City Concern, otherwise known as CCC. And she's been there since 2006, serving as a medical director, and then joining CCC's executive leadership team as chief medical officer. Since joining CCC, Rachel has overseen inpatient and outpatient alcohol and drug treatment, primary care, and mental health care. She has developed key strategic initiatives and stakeholder partnerships to respond to community needs and has championed data-driven models of care for specific populations, from expansion of treatment for homeless people with opioid use disorder to an advanced medical home for medically complex homeless individuals. She earned her bachelor's from Brown University and her medical degree from Dartmouth Medical School. And she'll be followed by Neeru Goben. Neeru serves at the Tennessee Department of Mental Health and Substance Abuse Services as the Director of Housing and Homeless Services, an office which provides leadership and management of 12 service delivery programs that collectively provides supportive housing, housing support, and homeless outreach services across the state. In his capacity, Neeru also coordinates efforts with the Director of Regional Housing Facilitators to promote the Tennessee Creating Homes Initiative, which he'll be talking about, and Creating Homes Initiative 2.0, and collaborates with a variety of stakeholders to further the statewide efforts to positively impact homelessness and to provide safe, quality, affordable housing opportunities for Tennesseans experiencing mental illness, co-occurring disorders, and substance abuse disorders. He earned his degree from University of Illinois, Champaign-Urbana, with a degree in psychology. And with that, Rachel, I'll turn it over to you to talk about what you've learned since the report and your reactions to COVID.
Will do. Thank you, David. And thank you to the National Housing Conference and to Kresge for supporting this. I think Alex is going to be sharing the screen for my slides here shortly. Wonderful. And I chose to think about this today in terms of health and housing and homelessness, kind of a 2020 snapshot. It's a time that I think we're all trying to, I think David Dworkin said at the beginning, navigate uncharted waters, but then what are the strengths that we draw upon to do that? And three words came to my mind, which are adaptation, resilience, and responsiveness. Next slide. So I'll start out here by giving you a brief overview of Central City Concern and specifically the Housing is Health initiative that was featured in the report. I also want to then pivot into telling you a bit about again, this idea of adaptation and response, what happened with COVID-19. But then I felt remiss in not also talking about really the elevated voice of our clients, of our residents in our housing, of our staff to advance equity and anti-racism, which had been an initiative of CCC for many years, but really has galvanized and accelerated in the recent months, and I think intertwines with our COVID-19 response as well, and then touch on some lessons learned. Next slide. So the mission of Central City Concern is to provide comprehensive solutions to ending homelessness. We've been around about 40 years and we're an organization, I'm a physician by training, so I'm used to delivering services. I do visits, I do procedures, I write prescriptions. The idea of Central City Concern is not so much to deliver widgets as it is to solve this problem, to advance solutions to ending homelessness. And in any good problem-solving exercise, you need to really understand what the roots of the problem are in order to be able to then address it systematically. So I've been using this kind of very loose logic model for the last several years. I saw it originally in a medical journal in the Lancet many years ago. And it's this idea that the drivers of homelessness can be broken into two factors. first are factors, or you could call them even experiences of an individual. Things like early ACEs, early adverse childhood experiences, serious mental illness, substance use disorder, a personal history of violence or traumatic brain injury, interaction with the welfare system. One that's not up there is age. Age over 50 is now in of itself an independent driver and risk factor for homelessness. But what's probably more important are the structural drivers of homelessness, which many folks on this call are aware of. The absence of affordable housing, the absence of meaningful wage employment, structural racism and discrimination. And I think now we're, in that last 10 years or so, we've started to see how the structure of our criminal justice system gives rise to homelessness. And these all can interact with one another to drive homelessness. But the point I often make, which I think is really important, is that we tend to load a causative analysis on these individual factors. But really what lots of research has found is that as these structural factors become more pronounced, that you need fewer and fewer, if any, of those individual factors to drive someone into homelessness and to keep them there. So attention to these structural factors is really paramount. Next slide. So as CCC has evolved, it's done in response to addressing both those individual factors and structural factors. So first, and Alex, you can just click on each of these as I talk about them. Safe, supportive, affordable housing. We have about 2,200 units of affordable housing with another 300 under development right now that really provides a wide range from very low barrier housing for people who may have serious mental illness, may have active substance use disorders, all the way to housing where people are seeking a recovery environment, and many sort of specific programmatic housing in between. Our integrated healthcare. We provide really a broad range of healthcare services to address some of those individual factors, often really tailored to people who may have been alienated or disenfranchised from mainstream healthcare systems. So we provide integrated primary care with very low barrier access to opioid treatment medications like buprenorphine. We have an extensive substance use disorders continuum from outpatient to residential to inpatient withdrawal management. And we provide specialty mental health services as well. On income and employment, again, another structural driver of homelessness, we support about 1,000 people a year in gaining employment with a pathway to meaningful wage employment, if that's not immediately available, with hundreds of employers around Portland. And then finally, this idea that I think of as the special sauce of Central City Concern is positive peer relationships. And the idea that rugged individualism isn't going to build someone's sense of community and belonging and self-sufficiency. One of the beautiful things about CCC is that about half of our staff themselves have lived experience of homelessness, of addiction, of serious mental illness, and are the mentors not only for our clients, but frankly for many of the other staff as well. Next slide. So the initiative that was featured in the in the report was, and which David referenced, is what was called the Housing is Health Initiative. And this was around 2014, 2015, as there was more money in health systems due to the Affordable Care Act, which was really beneficial to everyone. And if there was a kind of a reckoning or a collective awakening among a number of CEOs of some big health systems and one Medicaid payer in the Portland metro area that you can see there, that, as David mentioned, the impacts of unhoused people were profound. They were affecting who was in their emergency rooms, who was able to be discharged from the hospital. And frankly, these health systems were finding that many of their own staff couldn't even afford housing in the Portland metro area. So rather than doing a number of piecemeal grants, they leveraged their investments in a collective impact investment of $21.5 million, which we were then able to leverage through low-income housing tax credits and new market tax credits and capital campaigns to about $90 million worth of development. And from that, we have created, these have all been open for a year or more now, almost 400 units of housing, some of which is deeply affordable at 0 to 30% MFI, all of which is under 60% MFI, both transitional and permanent, and both single room occupancy and family housing, as well as an integrated clinic on Portland's east side. So I'll just show you these projects really quickly, and then we'll talk a bit about how COVID has impacted our continuum of services. Next slide. So one of the developments called the Charlotte B. Rutherford Apartment, named for a really prominent justice and civil rights leader in Portland, is 51 units of affordable housing for families at 30 to 60% MFI. And this is a right to return building. So particularly Black and African American households who were displaced from this neighborhood have priority and preference to be housed here. Next slide. The second development is called Hazel Heights. This is out on the east side of Portland. In many cities, as the inner core has become more gentrified, people of low income and people of color are moving further out. And in Portland, this is particularly into the eastern part of town. So being able to build affordable housing for families is really important in that part of our community. And Hazel Heights is our largest building. It's 153 units, all of which are 2-bedroom, particularly for families that are exiting transitional programs, such as that could be from residential treatment, from our transitional housing and other places. Next slide. And then the flagship is the Blackburn Center, named for my predecessor and mentor and boss for many years, Ed Blackburn, whose brainchild this whole Housing is Health initiative was. This is also on the east side of Portland. It has 175 units of affordable housing, which is the whole third floor is just medical respite housing, people who are leaving the hospital and can't be discharged, shouldn't be discharged to the street, and so come in for medical respite, staying 30, 60, 90 days with integrated case management and healthcare. And then the floors 4, 5, and 6 are recovery housing, both transitional and permanent. And then the first 2 floors are an integrated, it was sort of all of CCC, what we do, kind of from a services standpoint wrapped into one. So a clinic inclusive of integrated primary care, substance use services, specialty mental health. Anyway, you can read it all there. And really starting to put all of these services, inclusive of case management, employment services, and even housing case managers from the upper floors, all working together in team rooms to provide true holistic care attendant to those social determinants that David was referencing. So we've still got a lot of kinks to work out. That is not an easy thing to do, to put all those functions in one room and tell them to have at it, but it's a really exciting project. Next slide. So along comes COVID, and I'll try to make this as brief as I can. Much of what we do, I'm sure similar to others, are essential services. All of our housing and our 24/7 services like residential and detox and medical respite care remain fully open. We made some space adaptations. For instance, anything that's dormitory style, we started spreading beds apart. There was no more collective meals. There's no medication passes were done at the bedside. There was also a really strong push to be able to get PPE and good hand washing protocol and all kinds of infection prevention in place. I don't have time to show it, but we made our own video to the song Safety Dance, but it's called Safety Stance. And anyway, if you're interested, it's a fun way to sort of highlight mask wearing and physical distancing and hand washing, all the things that Dr. Benjamin referenced. Because there's a lot of housing experts on this call, we changed the use of all of our community spaces. Again, sort of the special sauce and glue of Central City Concern is social connection. So we unfortunately had to tell people that you can't really congregate in those spaces, but I'll talk in a minute about how we tried to restore some of that healing connection. Did lots of work with the HVAC systems to be able to increase airflow. And then along came the wildfires and we tried to reverse all of that, but that's another story we don't have to talk about today. And then supporting a lot of folks with rental assistance. We've been able to keep our employment services fully operational. Those are ones that can be done entirely virtually. And while the nature of the jobs has changed somewhat, you know, there's less food service and retail and more sort of delivery and other types of remote work, it's still going strong. Across our clinical services, this is an area where we really have changed and innovated every day. We, over the course, probably like many healthcare organizations, very quickly went to a blend of virtual, either virtual visits, either by video or by phone, but by virtue of the population that we serve, we kept a fair amount of our in-person services in place, particularly in primary care. As we have recognized that, as Dr. Benjamin stated, this is kind of the new normal for a while. You know, there's no rush to vaccine in this case. We've been gradually on a site-by-site, program-by-program basis, working with leaders and staff in each of those sites to say, okay, what can you bring back comfortably? One of the earliest things was our addictions program said we have to bring groups back. It is it's the heart and soul of what we do in substance use disorders treatment. So we've brought groups back and other on-site services as staff is ready. Through fundraising effort and CARES Act funding, we've been able to distribute phones and tablets and broadband access to many of our clients as well as our residents. And forgive the goofy picture, I couldn't find a better one that didn't have that kind of hipster guy in it, but one thing that we have been working with is the idea of a telesuite, particularly in our housing and in our residential treatment programs where people might not have privacy or access. So that's kind of this space age, fully wired phone booth where people can connect not only for healthcare appointments, but with case managers, with parole officers, with family, with kids, just really trying to create as safe and respectful a space as possible for people to have those kinds of connections. And then as we've started to bring folks back on site more, again, being very attendant to our staff and clients of color. In Oregon, and Dr. Benjamin mentioned the disproportionate impact of COVID on communities of color. In Oregon, that's particularly profound for the Latinx population. 40% of the COVID infections in Oregon are in the Latinx population. So for instance, we have a culturally specific program called Puentes that is monolingual, monocultural addictions and mental health program for Latinx families. And those leaders and staff have said, we think for the safety of ourselves and our clients, we're going to remain virtual with some targeted outreach. Couple other things that are of interest. We started up a food service for a while as food banks and traditional soup kitchens were less available to both our residents and our clients. And we really found that this was an opportunity to better integrate housing and health services. We're a big organization and we are, I'll admit, we're siloed in many ways, except for the Blackburn Center. So being able to start to integrate infection prevention practices, we set up a COVID triage line where there's always a physician on call and any housing case manager or resident services coordinator can call anytime with a COVID concern, or now even a health-related concern, or recently a smoke-related concern about any of their residents. And the glue that held this all together was lots and lots and lots and lots of communication. We started out with, actually it was twice a day, and then daily meetings with all of our managers, which is about 70 or 80 people, and then have gradually spread those out. But we found that particularly an online platform allowed us to just be working through problems and talking and communicating all the time. Next slide, and then I'll wrap it up. As I mentioned, I did just want to touch on the importance of our staff and client and resident focus on equity and anti-racism, which was brought to the fore by COVID, and then even more so in late May with the murder of George Floyd, and really the powerful protests that we saw in our community. This was led by our Chief Equity Officer, whom I just need to acknowledge and call out. And what she really advised us all to do was not to rush. She said this is as much a time as any to go slow in order to go fast. So let's just listen for a while. And we convened listening sessions and reflection circles. Our Black and African American employees self-organized an Elevating Black Voices town hall to set up a set of commitments to anti-racism within the organization. And you can see some of them there, more training and advanced in the foundations of equity, looking at our quality metrics, particularly our COVID outcomes and COVID testing, what's our governance framework. Our residents and clients have doubled down in public policy advocacy around things like public safety reform, criminal justice reform, housing reform, increased opportunities for all of our staff through leadership development and talent acquisition. And it's important, it was such an interesting moment, because I actually think COVID taught us how quickly we could come together to talk and solve problems, and really grounded in principles of listening and learning. We've been able to really make, I think, some good planning and good progress and good understanding across the organization that really hadn't been there before, despite years of work in equity. So last slide, just some lessons learned, I guess, is I've been amazed by the remarkable resilience of our staff and clients and residents. Just what a wellspring of energy and creativity there is when you didn't think there was anymore. And that these forums for listening and learning and planning, even in sort of rapid fire response, are really not just essential, but nourishing. I found that our communities are looking for solutions to these really complex intersectional problems. They're looking to organizations like ours that can do housing, that can do healthcare, that can provide employment, that can that are thinking about equity and disparities, and that we're sort of at the point of the spear for much larger problems. And so being able to articulate these has been a really important part of our work. And finally, as I keep reminding our staff, like, look, we don't have, this is all hard stuff. It's not going to be perfect. And we don't even have to be super innovative or cutting edge. We can, borrow from other places, but we do need to be, let's just be responsive. Let's be listening and thinking and planning and then responding in kind. So thank you. I will stop there. I think my information's on the next slide, and really appreciate this opportunity.
Thank you, Rachel. We could spend a lot of more time just going into greater detail on each of those slides in your deck. But I do want to give some time to Neru and also get to questions that are beginning to emerge from our audience. So Neru, take it away.
Well, thank you very much. I want to thank the National Housing Conference and you, David, and the Kresge Foundation for this opportunity. I'm excited to share perspectives with our audience today regarding health, housing, and partnerships, particularly with the Tennessee Creating Homes Initiative. Well, let's see if I can move my slides here. There we go. So to give you a very brief synopsis, the Creating Homes Initiative, also known as CHI, started in 2000. And over the years, it has been a successful model of strategic collaboration and assertive partnering to leverage funds and resources to create safe, quality, and affordable permanent housing options for Tennesseans with mental illness or co-occurring disorders. And in fiscal year 2020, CHI expanded to include service to Tennesseans in opioid and other substance use recovery. This component in particular is known as CHI 2.0. All too often, housing is not considered a component of health in our community, and yet we know that people experiencing homelessness or risk of homelessness are better able to manage their health with quality housing, which couldn't be more important during this COVID-19 pandemic. For CHI and all other programs, 3 key principles within our department's mission statement drives what we do and how we do it. By ensuring our programs connect and create pathways that promote resilience, recovery, and independence, we create an environment in partnership with our providers and the community that is conducive to improving health outcomes. Critical to this end are components such as access to mental health care and primary care, the implementation of integrated care, which promotes increased continuity and coordination, affordability of housing in regions across the state of Tennessee, access to transportation and or telehealth technology to ensure adherence to treatment and care plans, the identification of supplemental resources in the area to help offset the burden of costs. Also critical and vital wraparound services such as peer recovery support and support and employment, where in Tennessee, the only evidence-based model, the individual placement and support model, is practiced. Also SOAR, which is a SAMHSA-led model to help people submit successful applications for SSI and SSDI benefits. The development and implementation of individualized plans to help people achieve their unique goals, and implementation of individualized plans to help people achieve their unique goals for successful community living. And of course, social skill building opportunities which can help optimize successful community engagement. So I want to talk briefly about our CHI team. Our CHI team has several different folks on it, and they serve different roles. We have our CHI 1.0 regional housing facilitators, as well as our CHI 2.0 regional substance use housing facilitators. And both groups of facilitators work with partners to collaborate, lend expertise, recommend financing strategies, conduct need assessments, and write grants, all to generate new, affordable, and quality housing options across the state in their various regions. We also have our Director of CHI Regional Housing Facilitators, who provides guidance, training, and leadership for our facilitators. She also coordinates with our Office of Housing and Homeless Services to ensure effective alignment between the intentions of the department and the CHI model as it relates to implementation across the state. We also have our Consumer Housing Specialists, which conduct community engagement to promote access to housing options, promote education about housing resources, and reduce stigma of mental illness, substance use disorder, and homelessness. And of course, the director, myself, of Housing and Homeless Services. And my role in this team is to work to provide programmatic oversight and to ensure information and developments from the department that are effectively delivered and disseminated to all of our CHI members. So who are our funding partners? We have a full spectrum of funding partners, and this list just gives you an example of some. We have partners that have larger pots, and we have such as federal and state agencies, all the way down to partners that have smaller, more local pots, which are often have less red tape, less restrictions, and less limitations, such as foundations and private contributors. We also have our stakeholder partnerships. And it's really vital to incorporate such a wide variety of stakeholder partnerships to expand our opportunities and optimize effectiveness of the projects at hand. So again, we have a wide range, including behavioral health treatment and service providers, service recipients, the regional HUD continuum of care organizations and agencies and groups, and the faith-based community, and all other partners in between. So what are the best practices in partnering that we find with CHI? Well, first, I'd say that a frequent engagement and follow-up is key. We find that relationships really benefit from having that extra layer of bond when you have frequent engagement. And that increases the unity and trust when you're developing plans and partnering to achieve certain goals towards your respective communities. We foster productive partnerships and symbiotic relationships. What I mean by that is that everyone should bring something of value to the table that benefits the others. This increases vested interest in projects. This is leveraging at its best. Funders want to make an investment in the work too. They want to make sure others have skin in the game. And leveraging incentivizes collaboration and efficiency by combining resources from multiple sources. We also find it effective to establish SMART goals, that is specific, measurable, achievable, relevant, and timely goals, and delegate action steps towards the achievement of these goals, and to track the status and progress of these action steps, and be prepared to adjust when needed. Also, listening to the community and your partners. This is your portal to the community, to community intel, to learn about need, to learn what's working well, to work what's not working well, and so on. Also, collective brainstorming with your partners for feasible alternatives or adjustments. In fact, of course, we know that most things don't always work out exactly the way we planned it, so it's critical to have that flexibility to be able to adjust, and you need to do that collectively. And funding opportunities and grants. Pay attention to what these funding sources say, and also what it doesn't say. There are very few definitions, regulations, rules, requirements, exclusions, etc., that are consistent across all funding grants and sources. So therefore, read the details, do your research for the particular grants and funding opportunities you're considering for the project. And when in doubt, we have found it is really effective to ask the funding source entity. Don't be scared to ask those questions so you can find out what is best and how your project will fit what's required in a grant opportunity. And also keeping your leaders informed regularly about what's going on in the community. Trust me when I tell you that our experiences that our leaders are actively working to respond effectively to the needs of the community during this particular pandemic. So now they're even more prone to receive this particular feedback. Speaking of COVID-19, I want to talk briefly about working through this pandemic and how have we kept the CHI heartbeat strong during these challenging times. So we've optimized the use of virtual technology and really worked to reframe our perspectives on this. I mean, we really want to make sure that we don't miss out on the value of in-person interaction, but making sure that we're looking at it and what is the value, what can we gain from actually utilizing telehealth technology that we haven't been able to do before. So for example, we found that this has actually increased our opportunity to engage, have more effective time towards engagement because there's a reduction in travel and commute time. Nothing replaces direct in-person communication engagement, but we have improved our bandwidth for responsiveness, which has arguably strengthened the trust component within our community and with the department. Our quality of communication has sustained, if not improved during COVID-19. And the virtual world has allowed for a wider, more frequent range of direct contact with the CHI team, which has actually decreased dependence on the excessive degrees of separation from the original source of information. Can't emphasize that enough. This is a very different atmosphere than what it was prior to COVID-19, or sometimes information gets channeled through from one person to another, and sometimes the message gets mixed or not entirely clear. So we have this opportunity. We've optimized that to increase our opportunities for more direct contact. And then also intra-agency engagement and partnerships within the state government. During this pandemic, we've actually found that various state agencies have found it really vital and important for us to connect and collaborate more than we have had before. And in fact, for example, we have been a part of a weekly and now has turned into a bi-weekly call that includes us, the Department of Mental Health, the Tennessee Department of Health, Tennessee Housing Development Agency, the Tennessee Department of Human Services, and the Tennessee Emergency Management Agency to connect with our community members that focus on the housing and homeless population across our areas so they can learn more about the developments that come from each of these state agencies, to be able to address things such as the CARES Act funding, and to understand where we overlap and how we can benefit to partner and better collaborate. So finally, what I want to do is just quickly highlight what we've been able to collectively achieve in Tennessee using this CHI model. So the numbers you see here is through our state fiscal year 2019. And we have effectively, through that time since the inception of CHI, we effectively leveraged $694 million from all partners across the state to achieve 22,900 housing options over that course of time. And I'm happy to say that we found it in fiscal year 2020 that we've been able to leverage an additional 61 million across the state for the creation of 2,500 housing opportunities during that new fiscal year. And of course, this is through a portion of the pandemic. So we're really seeing how we found a way to make sure that we are moving forward in spite of some of the barriers that we initially saw when the pandemic hit and so much uncertainty that has come into play. I would love to go on and on, but I know for the sake of time, I want to make sure that we can, I give just a brief synopsis there. But if you are interested in learning more about the Creating Homes Initiative and the Office of Housing and Homeless Services with the Tennessee Department of Mental Health and Substance Abuse Services, my contact information, as well as our Director of Regional Housing Facilitators, Ms. Jeannie Price, her contact information is there, as well as our department's website. David, thank you for this opportunity.
Yeah, thank you, Nero. I've always been impressed by the level of non-siloed thinking in the state of Tennessee. It's not a virtue that you find necessarily in government. I was responsible for bringing your former Commissioner of Human Services, Raquel Hatter, to be our Managing Director for Human Services at Kresge. So I've become familiar with how Tennessee operates, so thank you. We do have some questions from the audience, but I wanted to start this off. Both of you talked about integrated services, and the impression that maybe the uninformed might get is, well, it's just like kumbaya. Everyone comes together and shares money and data and hands off people seamlessly, but I know it's a little more difficult than that. Could you talk about the barriers that you have encountered? Because these are like not just integrating services, it's really integrating systems, which means complex rules, regulations, funding requirements, et cetera. So how have you experienced that in your projects? And Rachel, why don't we start with you?
Thanks. It's a great question. Yeah, I think as I mentioned, the Blackburn Center has surprised us with what we thought were such simple things. Put everybody in a room together and the magic starts to happen. It's much more difficult than that. I guess I would, I'll try to start with a solution because I think that's an easier way to think about it. One of the best ways to me to try to break down a complex issue is you kind of have to subdivide it into its component parts. And one way to do that in our work is to think about what are different populations, what are different groups of people that kind of hang together kind of conceptually that we can design care and funding and regulatory requirements around. So for instance, if there are individuals who are in early recovery and they're in our recovery housing and they're in our outpatient addiction services and they're getting primary care, which comes along with hepatitis C treatment, how can you start to think about that population? And so the things that can be really difficult there is, you have issues of HIPAA, as Dr. Benjamin mentioned. When you're in the world of substance use disorders treatment, you also have to consider 42 CFR Part 2, which specifically protects privacy for people with substance use disorders. And so you have to actually start to think through, okay, what information can be shared and what can't. So we've set up a system of firewalls in our electronic health record, as well as a pretty elaborate system of releases and how to notify people if you could even talk to one another about that, just even that given population. That in and of itself takes a lot of time. Then you have to also think about what's the interaction with housing just between those in health services from an integration and from a communication standpoint, ensuring those releases work across. I think the second thing that you also have to then think about is what are the shared goals, what are the goals of this individual, and how are those goals being documented and participated in? And I can say, I think the shared care plan is for us still kind of the holy grail of integration. It's very hard to get a care plan which is useful to the clinician or to the case manager or to the housing specialist. That's useful for them, is useful for whatever documentation they need to produce for a funder, and most importantly, reflects what the client needs. So I think that's another barrier that we haven't really been able to solve for. And I think at this point, and I think the third one is around culture. So again, this sense of, I'll just take this one population, for instance, that I was describing. There's recovery itself has a lot of different cultural approaches to it. Within our organization, some people are clinicians and think that recovery, if you can utilize a medication, let's say like buprenorphine or naltrexone to help with that, and then that's helpful to the client, so be it. There are other parts of the organization that think, gosh, that isn't real recovery. So we've actually developed, again, it's back to that old listening and learning and how are people coming together and talking, really intentional conversations about, what's our common shared definition of recovery, and what are the different roles and the different approaches that people may have. So those would be, I think, and then funding is just a whole different idea that you have to, unfortunately, I think as a single organization, we have just felt like our job is to try to, have these elaborate accounting systems that knit all of the funding together. I would love to be able to see funding that's actually designed for the health of and the well-being and the housing status of a population, because then I think you start to see mutually aligned incentives as opposed to incentives which sometimes diverge. So that's one we haven't quite been able to take on yet, but on sort of our daily basis, making sure that you've got enough regulatory compliance around communication, that you are sort of trying to get to this idea of a shared care plan, but underpinning it all is good conversation about culture and frankly ideology, that when you're doing complex work is going to arise, and you just need to devote the time to work through it because it's not going to resolve itself on its own.
Mm-hmm. Yeah. Getting to a more patient or person-centered way of thinking about the process. Nehru, what about you?
Thank you. I think for us, I would say that probably the best thing for me to do is share a real-time example. As I mentioned at the beginning of my sharing the slides, that we had expanded the Creating Homes Initiative to incorporate CHI 2.0, which was for housing focused on individuals that are in substance use recovery. And we have established a renewal, if you will, of our partnership with the Tennessee Housing Development Agency, that they had agreed to provide a one-time match funding to the amount of $3 million to get that particular part of our initiative off the ground. And in our collaboration with them, and this came in the form of a grant opportunity funding announcement for folks to submit applications to get funding to develop creative housing for this particular subset population. And what we were able to do is when we collaborated in developing the program description and the outline of what this is, we've learned that the structure that was in place had some things that may have been barriers, particularly for recovery housing. Recovery housing, a lot of the folks that work in recovery housing, they're subject matter experts and are probably the best suited to provide the services, the wraparound services that are needed for these folks. And I think the infrastructure is, side note, is the infrastructure of housing is one piece, but that doesn't create the home that an individual needs when they are working towards recovery in this particular community, part of our community. And so the support services need to be in place. And so a lot of the folks that are really excel at this don't have the years of experience in the housing realm that have put up barriers, you know, with their normal, with THDA's normal structure. So in our negotiating for this, we started to explore, you know, can we look at this, and is there a way to find a different way to address this so that we're not compromising the integrity of the model or the program that they set forth, but it also allows for opportunities for those who can do the work that needs to be done in this for this particular unique need. How can we implement that? And what we were able to do, they had a 2-year requirement, for example, for experience in housing to be eligible to apply. And so some of our providers had less than 2 years, and totally understood why they had that requirement. They want to make sure that the investment is from a solid, reputable organization that has the history to make sure that this is sustained. But because we know that housing in itself, and we're talking about health and housing, requires all these support services there, we say, could we consider, if they have experience in providing the support services to help individuals sustain that housing, can that be considered as part of that 2-year requirement? And after some discussion and negotiation, we were able to establish that. And so that opened the door for those who were really had the means and the expertise to be able to do this and do this well. And we were successful in getting folks to apply and have some really substantial, valuable applications that were submitted as a result. So, you know, my takeaway from that has been that have those discussions, even, and we know at the state level and the federal level, there's policies and red tape, and some things are just not negotiable. But sometimes you never know, you know, until you have those discussions and find out what was the genesis of a certain practice that was put in place, and to explore opportunities. One thing that our commissioners always taught me is don't come with just a problem, propose a solution. And so we practice that. And so when we do that and present those, sometimes we have opportunities to win and be able to make adjustments that did not necessarily compromise things as they were originally intended. But it also at the same time allows us to make sure that what we're doing progresses and it keeps up with the climate in the community and the folks that we're working to serve. Because in mental health, it is very, and in housing, it's a very much dynamic environment, and we need to be able to adjust to that, and the system needs to be able to adjust to that.
But even that solutions-oriented mindset, which I think, Rachel, you also mentioned, is actually a big culture issue in a lot of places. And people sometimes can't get beyond that. The question from the audience for you, Neeru, somebody talking about issues, the rise of drug abuse in Tennessee. What kind of progress are you seeing there?
Well, what we're seeing, one thing that we're seeing, we have our Department of Mental Health and Substance Abuse Services has 2 major divisions that actually work in actual service delivery. Of course, the Division of Mental Health Services, but also the Division of Substance Abuse Services. And so because of that, we actually have the opportunity to devote a lot of professional attention, you know, in the community for this particular need. And we have been seeing, you know, over the past, I would say the past 5 to 10 years, a significant uptick in the use of substance use, particularly in opioid use disorder. Our department is very good at working to identify need, to learn within the community, establish task forces. We have connected with an organization that we fund known as TATAS, which is the Tennessee Alcohol and Drug Association Services. And they really focused on providing feedback and engaging the community to inform us on what needs to be done. And so with that, we are exploring ways to integrate, you know, ideal practices such as MAT, you know, and implementing that in an atmosphere that probably has so much barriers. The community is very averse to MAT because of a lot of unknowns and a lot of fears, you know, a lot of risk involved. But if we look back on what we've seen before in other areas, let's say for crisis services, I served in crisis services for many, many years. And what we work to do is we work to deinstitutionalize folks that were at the state hospitals and the mental health institutes for many, many years. And there was fear of having folks coming out of there that they felt needed to be in a hospital for a very long time. But we said we can do this. And how do we do it is to make sure that we equip the community with the things that the folks need so that they can successfully live in the community in spite of what they are working and dealing with, that we can actually support them and help increase their integration. So we take that same model and do it in the same fashion in substance use and substance use recovery. So there's a wide variety of programs that exist. Of course, I don't know if we'll ever match the need with the resources, but just to be able to become innovative, to continue to get creative, find out how we can make sure that our services match the need as best as we can, bring in the right partners, and listen to the community. This is really, really critical for us so that we can say, we've heard it. And one thing that we've seen that happen in the past few months is there is a Project Rural Recovery that Tennessee has done, which provides a bit of a mobile behavioral health, mental health service in the more rural communities, and that also addresses substance use disorder. And so a lot of folks that are living in rural areas across our state don't have the means to get to the nearest healthcare center or substance abuse support care centers or anything like that. So let's bring the services to them. So this is a very exciting thing, and we're happy to be able to get this off the ground. We've got 2 providers in the state that's running that right now and getting things off the ground. My hope is that we'll see that this has so much success and value that there'll be a greater investment, at the public level to make this happen and make it a more of a fundamental element within our service continuum.
Great. Thanks, Nero. There was a couple more questions from our attendees. Is it okay if we try to answer these 2? I know we're kind of running up on time. Okay, so I got the go ahead. Maybe I'll direct this next question to you, Rachel. This is from a CDFI. So you're probably familiar with these community development financial institutions who really broker a lot of the dealings with LIHTC, et cetera. And the question is about, developers and financial institutions typically look at the real estate development and they don't consider the broader community planning level. So is there a way to, or do you know of examples where, a development, let's say permanent supportive housing development, has been considered in the context of other kinds of services and amenities?
Mm-hmm. I appreciate your, what's the word I'm looking for? Your confidence in my ability to, again, I've come up more from the healthcare side of the organization, but have tried to really, since becoming CEO a couple of years ago, increase my learning curve around the real estate development side. I love this question though, because I think we have struggled within, as we've done housing projects, within the confines of traditional funding mechanisms, to be able to pencil in the right amount, not just of literally real estate, like enough community spaces, for instance, as opposed to just units, but then also to be able to provide the amount of supportive services, and not just the typical sort of resident services coordinators and community managers, but also the integrated, often mental health and addiction services. So I would say one of the more successful models that we've seen in Portland recently is actually a joint effort between the Portland Housing Bureau, which is sort of under the city, and then the Joint Office of Homeless Services, which has city but also county funding, to put out NOFAs for projects where the Housing Bureau provides some of the capital funding and operating, but the county then provides support, like ongoing support, at least 5 years worth of supportive services, inclusive of, again, not just the resident services, but actually on-site mental health support and case managers. And then the geniuses in the real estate world kind of leverage that in with other sort of, LIHTC financing. But that was a really innovative NOFA that we secured a couple of years ago. And it was also a recognition of the importance of single room occupancy housing. As we know, SROs have been the affordable housing of choice or of default for the last century, and we've seen them really, really decline in our downtown core. So there was a recognition of the need to reinstate that SRO housing, to have city funds to help support its development, and then to couple those with county funds to be able to provide 5 years of supportive services. So it was a really nice, very, again, popular, and this was specifically for people with serious and persistent mental illness, a really nice population-focused point of view, understanding the different services and twined funding that would be required to make that happen.
Great. I will sort of add to the question here that the person, you should look at LISC, Healthy Futures Fund, which is something we help finance using with a variety of CD5 partners, which is funding precisely this kind of more comprehensive development where you might include an FQHC, for example, within a housing development, or was even one with a grocery store connected to a housing development. So there's Cape Verde, and I believe a grocery store in Massachusetts providing ethnic foods to the population. So you should check that out. Last question, maybe both of you, just maybe if you have an answer. What HUD programs do you believe would be most effective in addressing issues of homelessness during COVID?
I can start that off, Rachel, if that's okay with you. One thing that we're actively working on, and then, my slide presentation, I kind of referenced it slightly about increase in the intra-agency engagement and partnerships with the calls that we've had with different sister state agencies that also include the Department of Health and the Tennessee Housing Development Agency and so forth. Also on those calls are a HUD continuum of care across Tennessee, and we have 10 continuum of care in Tennessee, and they are part of those calls. And the primary focus of that was to engage them to learn about what's happening in the community, because they are the pulse on a regional level as to what's happening in the homelessness and housing community across each state in our country. And so what the primary focus has been is the CARES Act funding. And CARES Act has come into play. And I think in this particular season, HUD has probably has had a lot of things flying their way at the same time. So sometimes we noticed instances where notices of funding was going to come in, but then there was determinations that were still pending to say, what was the structures and parameters about that. So we really had to get other state agencies involved, and also to explore what the needs are. And we found that there was afforded flexibility in that particular act for funding, and it being a formula grant, actually provided that opportunity to do it. So I think in COVID-19, what we're finding, and it's kind of getting more off the ground now, is that access to that funding and how it's going to be disseminated regionally, and some of the other agencies that work in partnership with our HUD COCs, and how they can receive some of that funding to support the COVID-19 pandemic. Also exploring in that particular grant or other HUD funding grants, how, for example, congregate sheltering has been a problem during COVID-19. So there are efforts regionally to say, what do we need to do? What can we do to get folks off the street, but not necessarily in this, mass sheltering type of atmosphere, so that we can reduce or increase social distancing and optimize quality quarantining, especially for that most vulnerable part of our community. And so a constant exploration about what the CARES Act funding can do and what it can't do, what it ought not to do, has informed that. We also have learned that, it may not necessarily be the HUD funding But because HUD disseminates the funding oftentimes to the state, a certain state entity, that the state entity that receives it for in Tennessee, for example, is THDA, they kind of help determine how it's going to be structured in the state. But then they also might say, well, this is what we need to do with some other sources of funding that we have in our shop that can help offset some of the things that may be negated as a result of the restrictions due to HUD funding. So sometimes it's not just the HUD agency that we need to look at, but collectively the entire spectrum of resources and pairing it with the need in a respective community.
Thank you.
Yeah, I'm less familiar with HUD funding because most of our support has come from HRSA, from the healthcare side. But two things just to add to what Nehru said that I think would be enormously helpful is additional funding for rent assistance. I think for affordable housing providers like ourselves, we're doing lots and lots of fundraising to help support rent for our residents who we don't want to evict on the basis, we can't and shouldn't and don't want to evict on the basis of rent, but how we're able to do that. And then to Nehru's point about congregate shelters, if there were funding to be able to buy up the underutilized assets we now see in our community around motels and rental properties, either to move people who are unhoused into those environments or to disaggregate those congregate shelters, those sorts of investments could then pay off for years to come, even after COVID is a thing of the past or less acute than it is now.
Okay, I know that we're well over time now, and there's a number of other questions. I'm not sure what the best way, can you guys see the Q&A?
Yes, I can see it.
You could type some while we're moving. I think we'll probably move to the NHC staff. You can
Okay.
those questions. Maybe that's the best way to handle that right now. And I've got a notice here from Alexandra to let you all know, everyone in the audience, that they will follow up via email with some of the questions and answers there. So with that, I will turn it back, I guess, over to turning over back to David. Is that?
Yep.
Okay.
Thank you.
Let me just thank
Yes.
both panelists. And I know that on behalf of everyone who's here, that there's a thunderous applause for your presentations. Just take my word for it. But thank you.
Thanks again. It was really a pleasure.
Thank you, David, and thank you, all of you. We really appreciate everyone for joining us, from our speaker, Dr. Benjamin, to our panelists. It was a great panel discussion, and all of our attendees. I want to especially thank our team, Andrea Nesby, Amanda Mitchell, and Alex Noble, as well as our board chair, Ann McCulloch, our sponsors, Zillow and the Kresge Foundation, and our major donors, JP Morgan Chase, Wells Fargo Foundation, and Bank of America, who really support us all through the year. If you like what NHC is doing, your support as a member is a great way to help us do more and get involved yourself. There are many levels of membership available, including individual memberships. Check us out at nhc.org. I also put the membership link in the chat. We look forward to seeing you all again soon. Have a great week, and please stay healthy.
Thank you very much.